Welcome everyone to session 6 or 6th edition of our Radiology Kahoot Quiz. How this works is I'll be showing a few questions on your screen. You have to log in using on the website kahoot.it. I've shared the pin in the comments and I'll share the screen again where you can check what the pin is. You'll get a few questions. You'll get options on your screen to answer them. Select the best possible option. And the person who answers the quickest will get more points, but at the same time, your answer has to be correct. So you have to be fast and you have to be accurate. So we have 10 questions. And don't worry if you are lagging a bit in the initial part of the quiz, because the last 3 questions have double points. So you can easily, even if you're behind, you can easily come to the top. Let me start sharing the screen with you. So that's the Kahoot pin. And once you log in, it'll give you a random name. You can select one. So that way, it's anonymous. Nobody knows what points you scored, except you, of course. And at the end of it, the winner will get a subscription to Radiogyan's case collection. We have almost 700 cases with the Antony type of cases with diagnosis, and 30 of them have detailed video explanations, and we are gradually expanding the case collection and the explanations. So for those who haven't checked them out, you can check the first link in the description or head over to our website and check out the case collection. We'll wait for a couple of minutes for people to join in. The reason for that is if you come in late, if you join in late for the quiz, if you miss on a couple of questions, you lag behind, and I don't want that. So we'll wait for a couple of minutes. So we have 23 participants so far. That's good. Okay, so I think we should start the quiz now. So best of luck, everyone. And the goal of this is to gamify radiology learning. And then at the same time, even if you don't win, that's fine. We're going to discuss a lot of interesting pathologies, interesting radiology pearls about the pathologies in these cases. For those who are on YouTube and do not, I would request everyone to participate, because active participation is the key. If you forget, if you get wrong a particular question during the quiz, you'll remember it better, and you'll remember it in your exams better. So do participate, but if you're not participating, you can participate in the live chat. You can type in the option or the answer in the chat section. So let's begin this fun Kahoot quiz. This has been our favorite, all our viewers, this is the favorite format. Every time I do this quiz, I get, oh, we need more of these, we need more of this. So let's begin the 6th edition of Radiogyan's Kahoot quiz. As always, the first question is a starter question. There are no points for this. So it's a trial question. What is this investigation called? Is it MRI? Is it CAT scan? Is it a CT scan? Or I don't have any idea about what this is. So on your Kahoot, on your mobile devices, click the correct option. So this is just a trial for you to get used to Kahoot, and it's so excellent. All of you have, most of you have rightly pointed out, this is a CAT scan. And let's move on to the real quiz now. So this question did not have any marks. The questions that follow will have points. So make sure you attempt these carefully. That's so you'll get a leaderboard after every question. Which of the following is not a differential for this incidental finding? So we have a contrast CT and T2 MR. What are your thoughts? Is it a neurogenic, would be neurogenic tumor, bronchogenic cyst, thymic cyst, or esophageal duplication cyst? Which of the following is not a differential? Excellent. So 14 of you have rightly pointed out a neurogenic cyst, neurogenic tumor. A neurogenic tumor will be more heterogeneous. It'll have a solid components. This is a simple cystic lesion. closely associated with the trachea. This was a bronchogenic cyst. Esophageal duplication cyst and thymic cysts are other cystic lesions of the mediastinum, although the locations may be slightly different. Thymic cyst would be more anterior. Esophageal cyst would be closely related to the esophagus. But again, neurogenic tumor definitely would not be a differential for this case. Bronchogenic cysts commonly present as middle mediastinal masses. They're very closely associated with the trachea and central bronchi. They usually have thin walls, and they most commonly show fluid contents, but rarely there may be proteinaceous fluids, which may give it mildly hyperintense contents, and the wall may show enhancement. But you'll never see complex nodular components in these cysts. So that was a bronchogenic cyst. Let's move on to the next case. So this patient presented with recurrent pancreatitis. What's the diagnosis? So this is an MRCP image. That's the CBD, that's the pancreatic duct. CBD drains here, pancreatic duct is draining elsewhere. So I'm just trying to help those who haven't had their MR postings yet. So what's the diagnosis here? So 21 of you have rightly pointed out pancreatic divisum. We'll go over the findings. For those who are in the YouTube chat and not on Kahoot, I think a few people, 58 of you are watching online, while the Kahoot participants are around 45. So you can answer these in the chat section on live chat. Okay, so let's go over this case. So this is an MRCP image. That's the liver, that's the pancreatic area. So MRCP is a highly T2 weighted sequence, which helps us to see fluid structures. So it's mainly done to look at the pancreatic duct and the biliary ducts. So these are the intrahepatic bile ducts. They combine. They join to form the CBD. The CBD is draining onto at the ampulla. However, normal anatomy, what you'll see is that the main pancreatic duct joins the CBD, and then both of them open at the major papilla or the ampulla. In this case, what's happening is that the pancreatic duct is opening separately. So this is what is known as pancreatic divisum. It is caused due to, it's an anatomical variant cause, which is seen due to failure of fusion of the ventral and dorsal pancreatic buds. In most cases, this will be asymptomatic, but what happens is that what is happening now is a large portion of the pancreatic secretions are now being drained into the minor papilla, which is kind of small. As the name suggests, it's a minor papilla. So because of that backup of those pancreatic juices, I think around 5% of patients can present with recurrent pancreatitis, especially common in children. The other differentials for this case were IgG4 disease. IgG4 disease can cause uniform narrowing of the CBD because of the thickening that it causes. This is definitely not that. Primary sclerosing cholangitis, the typical imaging feature would be string and would be a beaded kind of appearance to the intrahepatic bile ducts. And finally, choledococele, there are different types. The choledococele would be seen as a focal dilatation at the lower end of CBD. So those were the other differential. The correct diagnosis in this case was pancreatic divisum. So Shraddha, you're not able to join Kahoot. I've shared the link here. I'll share it again. Okay, so hopefully this link works. So join at kahoot.it, Kahoot.it, and the pin that is 976893. I've shared the pin in the chat again. Okay, let's move on. Okay. Elderly gentleman, which of the following is not a differential for this case? So this patient presented with right-sided facial numbness. Which of the following will not give this kind of imaging appearance? So we see a lytic lesion involving the skull base on the right. We have CT and MR images. CT in the bone window, and this is MR post-contrast. So 14 of you have rightly pointed out. So the point that I was trying to drive home here is expansile lytic bony lesions. So there are very few malignancies which can cause this kind of appearance. Renal cell carcinoma would be the most common. Then there's thyroid cancer. HCCs can cause this kind of appearance. Pheochromocytoma, melanoma, and finally gastric carcinoma is also a differential. Prostate cancer, although in some cases can give rise to expansile mets, but the classic imaging appearance of mets from prostate would be sclerotic lesions. There may be some expansion, but they usually are not lytic. So that was the correct answer here. All the other three can cause lytic expansile lesions. Okay, let's have a look at the leaderboard. So Melodic Gator is with 2,350 points is leading, while the others are not far behind. And remember, the last three questions have double points, so you can easily get over. You can easily come up and climb at least 10 spaces if you get the last three questions correct. So do stay until the end. Okay, next question. Question number 4. This patient presented with resistant hypertension and hypokalemia. So what is the diagnosis? So we have an axial and coronal post-contrast CT. There's a large solid heterogeneous lesion superior to the kidney. Which of the following would be the differential for this, the main differential for this case? Okay, so we got a mixed kind of a response. 13 of you got it correct. You said adrenal carcinoma. 6 of you said adrenal adenoma. I'll explain you why this is not an adenoma, and it's good that a few of you attempted. This was the point that I put adrenal adenoma out there. Pancreatic neuroendocrine tumor is a possibility, but the history says hypertension and hypokalemia, so they are not usually associated with these. Okay, sorry about that. So you see the pancreas here separately, and there would have been a rind of pancreatic tissue here, although in single images it is difficult, but the history also helps. So definitely not a pancreatic neuroendocrine tumor. Renal angiomyolipoma, that's also not correct. Angiomyolipoma, as the name suggests, there will be some lipomatous component, especially when the lesion is that large. It will be very rare to have a lipid poor angiomyolipoma of that size. The other thing is, again, in single images, it's difficult, but there is a fat plane separating this from the kidney. So this is favored to be more of a suprarenal lesion rather than a renal lesion. Now coming to an adenoma versus an adrenocortical carcinoma. Adrenal adenomas are usually very small. Anything more than 4 centimeter or even 3 centimeter, you should not be calling an adrenal adenoma. A large tumor more than 10 centimeter, especially heterogeneous like this with areas of calcification, the first and the main differential that you should talk about is adrenal carcinoma. And these are very aggressive tumors. They present very late and they metastasize early. So the earlier you diagnose these, the better it is. The caveat here again is that make sure that even if don't put ROIs and try to see the Hounsfield units for such large tumor, anything more than 4 centimeter in the adrenals, despite whatever Hounsfield units it is, that needs a biopsy for confirmation. So this is definitely not an adrenal adenoma. This was an adrenal cortical carcinoma. So 13 of you have rightly pointed out. Correct. So before we move on, we have 80 people on YouTube watching us live, and we only have 2 likes. So hit the like button; it's free. It just helps the algorithm to share with the video, and it reaches to more people. So if you're liking what we're doing so far, hit the like button. That also gives us motivation to do these more often. So let's aim to get 40, at least 50% likes. So hit the like button on YouTube, so that this video reaches out to more people. Let's move on to the next case. So case number 5, midway through the quiz, this middle-aged female presented with enlarging painless neck mass. We have ultrasound images of the thyroid, grayscale and color Doppler. So which of the following would be the best possible answer for this? Would it be de Quervain's thyroiditis, multinodular goiter, Hashimoto's thyroiditis, or Riddle's thyroiditis? Okay, so 19 of you have got this one right. Let's go over the imaging features. So you see this, the right thyroid lobe is slightly enlarged. It's hyperechoic. There are these tiny hypoechoic areas where the rest of the parenchyma is quite hyperechoic. And on color imaging, there is increased vascularity. So increased vascularity suggests inflammation, some form of thyroiditis. So this was Hashimoto's thyroiditis. The other differentials, multinodular goiter, you'll see actually like multiple nodules. And in cases where there's diffuse enlargement, where you're not able to see each nodule separately, the gland will be very large. This is not that enlarged. So this is not multinodular goiter. Coming to the other thyroiditis that I mentioned in the differentials. So subacute thyroiditis or subacute granulomatous thyroiditis, which is de Quervain's thyroiditis, that will show as hypoechoic areas with decreased vascularity on grayscale. This is definitely not that. Riddle thyroiditis is more of a fibrous, infiltrative kind of thyroiditis. Again, not very common. The thyroid gland will be significantly enlarged and will see infiltration into adjacent soft tissues. So definitely, this is not Riddle's thyroiditis. This is the classic imaging appearance of Hashimoto's thyroiditis. So you'll see in the early phases, there'll be hypoechoic nodules, while as with increased vascularity and increased hyperechoic, the rest of the parenchyma will be hyperechoic. While as in the later stages, you'll see linear hyperechoic strands throughout the gland, and the vascularity will be low. Okay, so by halftime, we have a new leader. Soaring Hen has bypassed Melodic Gator. So let's see, and I guess everyone still has a chance. So let's move on to the next question. Question number 6, which of the following is not a differential for this case? So is it an angiosarcoma? Is it hydatid? Is it prior trauma? Or is it congenital? So we have axial unenhanced CTs at the level of the upper abdomen. There's a large cystic lesion in the spleen with peripheral calcifications. So this is basically a cystic splenic lesion. The common differential for that would depend on which part of the world you're looking the case at, which part of the world the patient is presenting from. In the developed world, the most common cause is trauma. So post-traumatic simple cysts from the spleen are common. In a country which is endemic for hydatid disease, this would be a hydatid cyst. That's a very typical appearance with peripheral calcifications. Rarely you may find true splenic cysts. Splenic cysts, simple true cysts are most commonly seen in the liver, but they're not very common in the spleen, but that's also a differential. The correct answer in this case was angiosarcoma. Angiosarcoma is an aggressive malignant tumor of the spleen. It's a very aggressive lesion with early metastasis. But it'll have that definitely will not have this kind of appearance. It'll be more heterogeneous and more infiltrative. So that's the correct answer here. And good that 23 of you have correctly pointed out this. So next question, which of the following is not characteristic of this liver malignancy? So we have an axial CT at the level of the upper abdomen. There's a large liver lesion, heterogeneous with lobulated kind of margins. Is it persistent delayed enhancement? Is it focal bile duct dilatation? Is it capsular retraction? Or is it arterial enhancement with washout? Excellent. Most of you got this one correct. Let's go over. So we have, as I was mentioning, a large heterogeneous liver tumor. We see this capsular retraction. Look at the capsule here. It's nice and smooth. Whereas in the region of the tumor, there is capsular retraction. There's some kind of fibrosis happening in this lesion that's pulling the capsule towards itself. So that's a clue towards the diagnosis. And that also affects the imaging appearance. So this is a mass-forming cholangiocarcinoma. So mass-forming cholangiocarcinomas, the typical imaging features are capsular retraction because of the fibrosis, focal bile duct dilatation. As the name suggests, it involves, so cholangio is a prefix used for anything related to bile ducts. So cholangiocarcinoma will affect the bile ducts, and you'll see focal dilatation of bile ducts because of obstruction. And because of the fibrosis, it shows persistent delayed enhancement. So what happens is that the intravenous contrast gets collected in these fibrous spaces, and that's why these tumors tend to show persistent delayed enhancement. What is not characteristic of this is arterial enhancement and washout. That would be an HCC. So that rules out, so that was the correct answer here. Cholangiocarcinomas will not show early enhancement and washout. Okay, question number 8. So these are the double point questions. So make sure you attempt them quickly and accurately. These will be a bit more difficult, and this will have more time. So you'll get 1 minute to answer each of these. So let's see who gets these ones right. So we have an axial CT at the level of the cerebrum, and we have a coronal CT of the abdomen. So on the CT brain, we see these subependymal calcifications, and on the coronal abdomen CT, we are seeing multiple solid renal lesions. So whenever I've talked about this many times on our YouTube channel, that whenever you get different systems, images from different systems, they're trying to point you towards a syndrome or a systemic disorder. So start thinking on those lines and put both together. Don't give answers in isolation. So is it von Hippel-Lindau syndrome? Is it neurofibromatosis? Is it Face syndrome? Or is it tuberous sclerosis? Excellent. So 28 of you have rightly pointed out this is tuberous sclerosis. These are subependymal calcifications. That's characteristic for tuberous sclerosis. This patient also had multiple cortical tubers, and on the CT abdomen, they have multiple RCCs, which is known in these patients. So the other findings would include a lymphangiomatosis in the lungs and a sclerotic bone lesion, as the name suggests. So this was tuberous sclerosis. Von Hippel-Lindau syndrome, you'll see cerebellar hemangioma, cerebellar and spinal hemangioblastomas, and multiple cysts in the pancreas, in the liver. That's more characteristic of von Hippel-Lindau. Neurofibromatosis, there's a bunch of finding. In the brain, you'll see foci of abnormal signal intensities. In the spine, you'll see neurofibromas and neurofibromas elsewhere on the skin, in the abdomen. And there are a bunch of findings there. And Face syndrome, I just put it there to confuse. I keep on forgetting the full form. So it's posterior fossa anomalies, hemangioma, arterial anomalies, cardiac anomalies, and eye anomalies. So definitely not Face syndrome. So this was our first double point questions. We have last two questions. Those also will be double point questions. So make sure these will be a bit challenging. So make sure you look at the question correctly. You look at the images carefully, and you can easily, if you're behind in this leaderboard, you can easily climb up by answering these last two questions correctly and quickly. So in our chat, we have everybody saying TS, tuberous sclerosis. That's correct. This was tuberous sclerosis. Before we move on to the last two questions, Soaring Hen has maintained his or her position at the top. Melodic Gator is not very far behind with 6,900 points, and Fearless Wombat, or in fact, all top 5 are in close competition. Each question will have 2,000 points. The next two questions, double points. So any of these can win the quiz. The winner gets access to Radiogyan's case collection. So once the quiz is over, make sure that you screenshot your name with the winner position and then email it to our email address. That's admin@radiogyan.com, and I'll let you know how can you get access to these cases. For those who don't win, you can always check out the case collection. It's available on our website. Okay, second last question. This is a slightly difficult one, especially if you're attempting it on your mobile devices. This patient presented with trauma and right foot pain. Ignore the 4th metatarsal fracture. That's not what I'm asking. My question is, what else would you look for? And I've given you a normal left foot for comparison. This is going to be a challenging one. Give it a lot of time. The question here is, where would you also look for? So look at the first. Oh, I meant second metatarsal base. No, first metatarsal base and middle cuneiform. That's correct. Will you look at the cuboid? Would you look at the fifth metatarsal base, or would you look at the calcaneum? So there's a subtle finding which has important implications. So Gopal Sharma says calcaneum in the chat. Calcaneum would be unlikely. We don't see the calcaneum here. We don't see much of it here. So that's not the correct answer. So this was a tough one. As I said, I expected this kind of response. So the correct answer here is first metatarsal base and middle cuneiform. Can anybody let me know in the chat why is that? Why should we look at that area? What's seen there? Okay, so this was a case of, along with that fourth metatarsal fracture, this patient had a Lisfranc ligament injury, and that was very subtle. If you zoom in on your devices, there is a subtle small density close to the second to the middle cuneiform. So that's where the Lisfranc ligament attaches. So one attachment is the middle cuneiform, and the second attachment is the base of the first metatarsal. So that's where. Oh, sorry. I'm sorry. So the Lisfranc ligament attaches to the medial cuneiform and this base of the second metatarsal. So that was the correct answer. Apologies for that. So I should have said second metatarsal. So the mnemonic here is E is equal to MC square. So medial cuneiform and the base of the second metatarsal. So that's where the Lisfranc ligament attaches. So, and that's where if you look at the Lisfranc interval here, that's widened as compared to the left. And that's what this patient had. We did a follow-up radiograph with weight bearing, and this accentuated that. And apologies for putting it as first metatarsal. It's not the first metatarsal. Okay. So this is the final question. What would be the subtype of renal cancer in this patient? So this, again, you're seeing two different images from two different systems. And what would be the renal cancer subtype in this patient? Okay, so we have, so the correct answer here is chromophobe, RCC. This was a case of Burnt-Hog tube syndrome. We see multiple lung cysts at the lung base and renal cancer. The renal cancer subtype that's common with Burnt-Hog tube syndrome is chromophobe RCCs. So that was the correct answer. Clear cell RCCs are the most common subtype. You'll see these lesions commonly show intense enhancements. Papillary RCCs are the second most common RCCs. They are prone to show hemorrhage. Medullary RCCs are not very common, but there's a particular condition where you can see medullary RCCs. Let me know in the chat which patients or which clinical pathology predisposes patients to medullary subtype of renal cell cancers. So let me know in the chat. And finally, chromophobe RCCs. Again, they don't have a typical imaging appearance, but they are seen commonly in Burnt-Hog tube syndrome, which was this case. So lung cysts, usually at the lung bases, and an RCC solid renal lesion, which is an RCC proven, unless proven otherwise. So let's look at the leaderboard. So Kamal Pant, that's correct. Sickle cell patients are prone to medullary RCCs. So that's the correct answer for that question. So let's look at the leaderboard. Final leaderboard for the 6th edition of our Kahoot quiz. So Clever Tiger with 9,820 points is at number 3. Fearless Wombat is at number 10. And the winner of today's quiz with 10,391 points is Melodic Gator. Congratulations to the winners. And even those who didn't win, there's a lot of learning. Apologies for the second last question. There was a typographical mistake. So let's look at the kind of, so the first question around, so that was the most difficult question, and partly it could be because of the error in naming the options. 23% could not get, only 23% got Birt-Hogg-Dube syndromes, but now you know. The other question that was kind of difficult was this one, the one with a suprarenal tumor presenting with resistant hypertension and hypokalemia. That's a functioning adrenal carcinoma, large adrenal tumor. Remember, adrenal cortical carcinoma should be your top differential. This one with a cystic lesion in the middle mediastinum, that was a bronchogenic cyst. Only 27% of you got this one correct, maybe because it was the initial question. This one here with a lytic expansile lesion, the correct answer there was prostate mets. Prostate mets won't cause this kind of appearance. They'll be more sclerotic. This was a trial question. We can skip that. And finally, this one with the liver tumor causing capsular retraction. Those are cholangiocarcinomas. Those will have delayed enhancement, and they won't have arterial enhancement and washout. So that was the correct answer. So that was a quick revision for the quiz. Hopefully you enjoyed this quiz, and let us know in the chat if you'd like us to do more of these quizzes. And you can check out the rest of the quizzes that we have done before, either by the link in the description, or you can click the link on the screen coming up. Thank you everybody for joining me live, and I shall see you guys in our next one. Bye-bye.